Dear colleagues, it's my pleasure to welcome you for this new webinar organized by the ENS School-Based section, and that is dedicated today to the complication that we can face during the school-based surgeries. It's an important topic. We always show you very beautiful videos, very beautiful results, but at some point there are also complications. And it's truly relevant to speak also about complications. It gives the surgeon some kind of humility, but a complication is always a way to learn something, and learning from the experience of the others, or maybe some wrong decision that we have taken, to give the opportunity to go further and to improve our future results. We have today a very interesting panel of speakers again, and I will show you the topic that will be covered this afternoon. First of all, we have Pierre-Hugues Roche. Professor Pierre-Hugues Roche is working in Marseille and will speak about arterial complication. I will then follow on the same topic. Then Professor Tatagiba from Tübingen will speak about the complication related to protrusial vein in posterior fossa surgery, an important topic. The next speaker is Professor Henri Schroeder, who will discuss the complication in microvascular decompression for hemifascial spasm and trigeminal neuralgia. Then Professor Kozu from Lausanne will discuss the risk factor of vascular complication during endoscopic transsphenoidal approaches. Professor Berouma from Lyon will discuss the vascular injuries during endoscopic endonasal approach. And finally, Professor Cavallo from Naples will discuss the non-vascular complication during this approach. So we will have a great webinar today again, and we will start with Professor Roche from Marseille. Please, Pierre-Hugues, show us your interesting case. You can share your screen. I will stop to share mine.
Okay, can you hear me? Yes, everything
yes,
okay?
Perfectly well.
I'm gonna try to find my slides here. Okay, good afternoon, everyone. Thank you, Michael, for your kind invitation. You're right. This is a huge topic, and this is something that is usually pushed under the carpet during the Congress. This is, of course, of paramount importance to deal with all these complications, which we are really reluctant to show, but which is probably the most important point. So I just prepare a case, and hopefully we have a good connection between our both topics. So just to introduce the case, this is a case of a patient I saw many times before the surgery. Actually, this patient was already operated several times in another center of paracella left side, paracella chondrosarcoma, grade 2. The patient underwent many surgeries with very traditional approach, not not epidural approach, but transcranial regular approach. And once the tumor was still growing steadily, with the patient complaining of some diplopia, we decided to operate. And I told him at that time, well, I will go through the epidural approach, a kind of Dolenc approach, and I'm not very concerned about your case because, you know, this is a slow-growing tumor. I'm very confident with this surgery, and everything should be all right. Well, we operate the patient. So I just want to show you not the case of the patient, because, you know, when the mess comes, usually you do not record. You record when everything okay. So just to show you a regular case of a chondrosarcoma, with this is a left side, a regular Dolenc approach with ACP resection. This is okay. This is the peeling of the outer layer of the cavernous sinus, and this is how it looks like. And this is a regular transcavernous approach, stimulation to record the oculomotor nerves and to select the good window, to open it and to remove the tumor. And in this case, by the way, this is not the case of the patient. This is a regular case. And we just had a very huge, very tough tumor with a bony texture. And in this case, I had to put the drill inside, and even to put the CUSA and even to drill inside to remove it as an eggshell technique. And in this case, you know, things happen very nicely. And in this case, the surgery was okay. These chondrosarcomas, usually they are very soft. In this case, I had bony tumor inside, but you can see this kind of soft tissue around the bone, and this is how it looks like usually. Well, this case was good, but in the case we operated, something came from the cavernous sinus, a huge bleeding coming from the cavernous sinus. It was coming from the carotid artery, and I could see anything. I couldn't see anything, so I had to plug it with Surgicel and cophonoids, and we pushed the patient into the angio ward, and the endovascular guy could put a stent. We administered immediately double antiplatelet treatment, and we put a stent inside, and the early post-op was really satisfactory. The vessel was patent and everything was okay. So patient went back to the OR. We closed the patient. I did not finish, of course, the surgery, and I left piece of tumor inside. I closed everything, but you can see the stent here on the inferior right panel here. Unfortunately, the day after, this is what we had. Patient became drowsy. We had this huge malignant infarction. We performed a craniectomy, and the patient could not survive. So this is a very dramatic and tragic complication of an intraoperative rupture of the carotid artery because of blind dissection inside. You saw the previous case. I put the dissectors, I put the drill, I put the CUSA, and in this case I was confident, and that unfortunately we had this problem. So how could we have avoided this complication? Well, while the surgical indication very pertinent in this case, I'm still convinced that we had to operate this patient regardless the approach, endoscopic or the Dolenc approach, because the tumor was still growing, and anyway, the surgery was, in my view, unavoidable. The issue was the preoperative identifications of the vessels. To be honest, I did not use at that time the micro Doppler. Today, I routinely use it. It's very helpful. Of course, we use the ICG. Of course, we have this kind of tool. This is a picture of a case we operate with Carlo Schaller in Geneva. This was augmented reality, and this is exactly the same situation. You can confirm the carotid route into the cavernous sinus. But if I had to look carefully the position beforehand, before the surgery of the carotid artery, I could probably avoid this complication, because I was really too overconfident with this surgery. What about the way to be prepared? Probably I should have done a balloon occlusion test before the surgery, just in case I had a problem, just to perform beforehand or during the surgery a bypass. Probably another way to manage the complication was to drill the petrous apex, to put a proximal clip, to remove the ACP, what we did, and to occlude the carotid at the level of the ophthalmic, and then to go inside the cavernous sinus and to stitch directly the hole we made in the carotid artery. Unfortunately, we did not, which means that the main message of my talk is we were not prepared to have this complication during the surgery because of overconfident behavior. So always be prepared to plan a backup solution in case of it can happen, is probably the main message of my talk. This is just to introduce your talk, Michael. Thank you for attention.
Thank you, Pierre-Hugues. Can you stop to share your screen, and I will share mine. Okay. Can you see my slides?
Yes, very well.
hear me and see my slide? Yes, it's in order.
Yes, yes.
So I will also speak about the arterial complication during transcranial skull-based surgeries, and I have a case who looks your case. So when we are making skull-based surgeries, we can face injuries to the arterial vessels. It can be during endoscopic transphenoidal approach, it can be during transperineal approach, and even during middle ear surgery. And it is reported by ENT, by sample here, there is a problem with the petrous internal carotid artery, which is protruding. And during even a tube placement for a myringotomy, there are some very important bleeding who are reported. And by sampling this paper, you see that they describe a pseudoaneurysm arising, and this pseudoaneurysm need to be treated with vascular occlusion and revascularization. So any surgery can be responsible for complication. Especially medial sphenoid wings meningioma. Those meningiomas have a tendency to engulf the ICA and all its branches. And it is well known that when the tumor is very large, the relation with the vessel is truly a concern. You can see in this series of large medial sphenoid wing meningioma that they are all in relation, of course, with the carotid, but also with the MCA and the anterior cerebral artery. The classification system has been described by Atul Gul when we have to deal with those meningioma in relation with the internal carotid arteries. And there are 4 grades, in fact, that can be in relation with the possibility to excise completely or subtotally or even partially the tumor. In fact, the meningioma can simply displace. It is the most easy situation, the internal carotid artery, but this artery can also be more involved. The artery can be completely encased, and the grade 2 is when the artery is completely encased but not narrowed. A more difficult situation is when the artery is encased but narrowed. In this situation, the rate of subtotal excision is higher. And finally, the score 4, the most difficult situation is when the contralateral side is involved with displacement of the contralateral internal carotid artery. Beside the relation with the internal carotid artery, the resectability of anterior clinoid meningiomas is also considered with 2 other criteria: the relation with the optic nerve and how the vision is involved, and finally the tumor site. And this grading system, based on a score between 4 and 10, give you the probability to totally excise or not the tumor. So, but what is truly important for this lecture is the relation with the internal carotid artery and the grading system that the authors used. This is a complication I faced, but since I moved to another hospital, I have not all the images of this patient, and as Pierre Grosch has told you, we always record when things are good, and when it went wrong, we have no time to record, and we have not the best pictures to show. In this case of anterior clinoid meningioma, everything was perfect. Sylvian Fisher dissection of the middle cerebral artery, vascular control. It was a navigated procedure with highlights of the vessel in order to anticipate their location. But what happens? An injury to the internal carotid artery. And finally, the only way to control this profuse bleeding, maybe 2 liters that were in the aspiration, was by tamponade. And you see here the Surgicel, and then to stabilize the Surgicel, a testicle that is placed. The only way to control, despite the proximal anterior clinoid process resection at the beginning of the procedure, the only way to control was tamponade. So what can happen during such procedure involving meningioma around the anterior clinoid process? This is the supraclinoid artery that is involved. So first of all, when it happens, you need a rapid vascular control. What does it mean? If it is possible, depending on the location of the injury, it's necessary to place temporary clips, proximal clips, but it is not always possible due to process and distal clips, depending on the level of the injury on the carotid itself or its branches. If the proximal control is not possible at this level, you need to go at the cervical level in order to make a temporary clipping if it is not possible to achieve a vascular control with tamponade and so forth. This is the second possibility, is to tamponade with Surgicel and with compression, as you have also shown, Pierre-Hugues, the compression of the vessel in order to stop the bleeding. Then, during your procedure, you have to think about the vascular reconstruction. And I have had a look on the literature on this topic. The primary repair of the arterial injury is most of the time impossible because the wall of the artery is extremely fragile. And if you enter the artery, you have a wall defect. So a primary closure is very difficult. I found this interesting paper. The author, after an injury to the carotid, tried a primary repair, but it was not possible. And then they restore the continuity of the carotid artery with a strip, a band, an hemashield strip that is turned around the injured vessel and then secured with a clip. They control with Doppler the patency of the artery. It's a way to reconstruct, when it is possible, an arterial wall after an injury. Some other authors have reported a direct revascularization. Of course, after having handled the vascular reconstruction or the vascular control with tamponade, you have to check the vessel permeability. And now we have Doppler, we have ICG video angiography that can be used during the procedure to check the distal patency, which is, of course, very important. Then what to do? Most of the time, I think people are stopping the surgery because after having had this concern, it is important to know how to ease the patient and to avoid any other complication. So the patient is wake up, and how to handle the patient in the postoperative course. First of all, it's truly important, as shown by Pierre-Hugues, to perform an angiography. In my case, we have performed an immediate angiography, and the result was perfect. We made then a second angiography after 1 day, and then we noticed the pseudoaneurysm. The constatation of a pseudoaneurysm, we need to do something. So we perform balloon occlusion tests, and then we go to an occlusion of the ICA proximally and distally. It's also important, of course, to have a distal occlusion of the ICA, but this strategy is, of course, dependent of the balloon occlusion test. And if it is not possible, you have to consider a bypass procedure or a stenting, definitely. And this article has reported 8 cases of urgent revascularization for several indications when there are an intraoperative injury of the internal carotid artery. This is one of the procedures that can be considered as well. So in my patient, I was lucky after occlusion of, and the patient was lucky. After occlusion of the internal carotid artery, the patient was well and recovered completely. So you need also have, at some point, have also and the patient a guardian angel. Always better to have one with you. So what are the lessons learned from this case? First of all, you have to be aware that it can happen. This is an important thing, and you have to anticipate as much as possible. So you have to be prepared. Now, in such situation, I always drape the cervical area. I will not open without any reason, but the cervical area is draped, always. The material, your clips, your suture must be close to the operating table, not maybe on the table, but close. We have not to need 5 minutes to find it if it is requested. It's close to the operating table. You have to stop the procedure when needed. Sometimes it is better to leave just a small remnant. This is a patient, another patient, with, you can see, complete encasement of the internal carotid artery. You see the distal vessel, the MCA, you see the involvement of the ACA, you see another situation that is more difficult when the lesion is calcified. This is the intraoperative view. You see how to handle this internal carotid artery. The distal you will see during the procedure, oh, it is difficult to dissect this artery. This artery was completely dissected without problem in this case. Nevertheless, you have to know when to stop. And those perforating branches, the choroidal artery, the PCOM, were very difficult to dissect. At some point, it is better to stop and leave a small remnant instead of making more dangerous dissections. And finally, any complication is an opportunity to learn. And this is truly important to consider, but try to have only one kind of complication only once, because you have learned from the previous one. Thank you. I will stop to share my screen. Pierre-Hugues, you are there?
Yes, I'm here.
You can hear me? Any comment, Pierre-Hugues, would you like to make after my talk?
No, I'm okay. I'm happy with what you said, and we do exactly the same. Be prepared. Be prepared beforehand, and of course, always be prepared to have a backup solution when it happens. So we have many questions in the participants ask many things. What I would add to my slides, when we put at the stance with the double antiplatelet treatment, and it was patent in the angio ward, I was very confident, but came and talking to the angio guy, the endovascular guy, he told me, well, the patient is not really deeply impregnated with the antiplatelet before the surgery. Sometimes it doesn't work. So that's why their stent occluded, even though we put it massive double antiplatelet doses during the surgery. And you were lucky, I was not. You're right, we need to have a guardian angel always, but be prepared, of course.
Any other comment from the others? Because we will move to other kind of complications. So if you have comments or the way to deal some difficult situation, please.
I had a case of a sphenoorbital meningioma, and I was unroofing optic canal, and then there was a small bone which was disturbing me, and I elevated, and then the optic strut went into the carotid, and there was a brisk bleeding, and I was lucky. I just put muscle on it, fibrin glue, and I stopped it for a while, and then the bleeding stopped. So if it is a small, sharp-pointed lesion, I think it's possible to deal it with reconstruction of the vessel wall. But this is rare. As you said, most of the time you have a rupture, a tear, and then you do not have a chance. But I think to occlude a bleeding vessel, muscle is the best material what we can have. And then, of course, we made a CT angiography afterwards, and also in the follow-up period. Unfortunately, there was no pseudoaneurysm.
And we must point out the fact that postoperatively, the patient must be carefully followed. The first angiogram we performed was very good, but the second one showed directly a pseudoaneurysm, and this has to be detected and, of course, treated, because if it is not treated, the evolution can be very bad, especially, of course, after tamponade. There are some questions, Pierre-Hugues, regarding the bypass.
No, to be honest, I don't have any huge experiences of that. You know, German colleagues, they are very familiar with the bypass. We do not do it routinely. Of course, when you have the possibility, the opportunity to stitch directly the leak with proximal and distal control, this is definitely the best way to manage. I had one case of a carotid bifurcation, not a rupture, but an injury of the wall, and because of the dissection of a meningioma with the scissors. By the way, microcisors, they are very efficient, but this is a very dangerous instrument. And I cut at the wall of the carotid bifurcation, But I was lucky enough to have a very clean tear, and we could put temporary clip on 3 vessels, ACA, MCA, and carotid, and stitch with it 2 A0 stitches. It was done. And I did what you did. I did twice an angio to make sure that the pseudo aneurysm did not come. But I cannot tell you about my personal experience about bypass because I'm not very familiar with that.
Mm-hmm.
This is very occasional.
Yes, I don't have experience in carotid damage, and I see some comments. Of course, the patient after the surgery is investigated by an angiography and a balloon occlusion test, and I don't think the bypass is directly performed. It's a second step procedure, and a bypass has to be prepared. You are not prepared normally when you are performing such procedure, and so it's a second step in surgery. So I propose to move now to the talk of Professor Marcos Tatagiba, who will speak us about petrosal vein management. Please, Marcos.
It's a great pleasure, Michael. Thank you very much for the invitation. Good afternoon.
Pleasure.
I'm glad that I have the opportunity to talk on this topic. We have studied for approximately 15 years. As you know, we are pretty much involved in posterior fossa surgery, and if you are doing that, you will confront with the petrosal vein in one or another day. Most of us are very much familiarized with these very important veins, and we know that injury to vein of Labbé or trolar vein may produce terrible problems, like this case here. Simple convexity meningioma, but the trolar vein was occluded accidentally during surgery, some hours after surgery, 1 day after surgery. This is a typical venous congestion that may happen. The patients can recover well, but for some days they can become very sick. The question is, what about the petrosal vein or superior petrosal vein? In this case, literature is extremely controversial, and even among experts, there is a big discussion whether petrosal vein can be occluded or not, if the patient is gonna tolerate this occlusion easily or not, whether we should avoid in any case. So there is a big discussion. When I was resident in Hanover under Professor Sami, I remember Professor Peter Janetta came a couple of times in Hanover to give lectures, and there was a discussion on that. And he used to say that the petrosal vein is not a big deal. You can occlude it, and in most of cases, nothing happens. And he was not so reluctant to occlude the petrosal vein in trigeminal neuralgia. On the other side, Sami said he had experienced some bad cases, and he would try to preserve always, if it's possible. So you see, two very experienced neurosurgeons at that time, but with different opinions. But maybe their opinions were not so different as we could imagine. So the petrosal vein, also called superior petrosal vein or Denge's vein, is actually a very important vein which is draining into the superior petrosal sinus. And this vein can be one or can be more than one. Up to 5 has been described. In most of cases, there are 3 veins. They compose the superior petrosal vein complex. And the petrosal vein is draining very important veins of the brainstem, mostly from the midbrain and cerebellar peduncle. And it can be classified into a medial, lateral, or intermediate type, depending on the area where the petrosal vein is entering the superior petrosal sinus in relation to the internal auditory meatus. So then you can divide these veins in different types. Important is to know that in most of cases, there are some anastomosis between petrosal vein and other veins in this area. But in particular cases, these anastomoses don't exist. In this case, the petrosal vein will be the most important one for this whole area. Important is to try to identify in which situation petrosal vein is cannot be divided. So I would like to share with you our experience in Tübingen, showing some cases, exposing a result of a retrospective study we have done. Then we have done also a radiological study on petrosal vein and the implications for neurosurgery. So if we are gonna operate, for instance, a petrous apex meningioma, petroclival meningioma, you may be confronted with this situation. This is a retrosigmoid approach. This is the cerebellum is retracted by this spatula. This is 7 and 8 complex, interauditory meatus. So you see that the trigeminal nerve is being displaced backwards and the petrosal vein is in between. This is one of the reasons some people prefer to go via Cavazzi approach in order to not to come in conflict with these structures. So we have a different opinion, but this is not the case right now. And you see here another case, petrous apex meningioma, 7 and 8 being displaced downward, jugular foramen, and here the petrosal vein. But notice the position of the spatula we use in those cases. We introduce the spatula from inferior to superior, and we open the inferior part more generously than the superior part in order to avoid stretching the petrosal vein. This is a very important step we have to teach our residents. Otherwise, at the first movement with the spatula, the petrosal vein is ruptured. So open the inferior part more than superior one if you want to preserve the vein. The question is it important or not? But not only for tumors. Here's a case of trigeminal neuralgia. I guess Henry is going to show some beautiful cases of his series. So in this case, we can only enter and expose the trigeminal nerve if we dissect the petrosal vein or one of the petrosal vein complex from the brain surface, cerebellar surface, in order to enter. So I don't use to coagulate this vein to enter this area. I do everything possible to dissect the vein based on some previous experience we have had on these cases. Okay, and so this is another case how petrous apex meningioma. You see the technique drilling of the petrous apex. This is the so-called suprameatal approach, and you see the trigeminal nerve is here, and the petrosal vein is above. This is a normal case. We could dissect the vein, preserve the vein, and remove the tumor. The question is what, and the case afterwards. The question is what had happened if we had closed the petrosal vein. So this is one case, it happened. This is a tentorial meningioma, tentorial notch meningioma. We removed the tumor, it was everything very, very nice, but petrosal vein was not preserved in this case. Patient did well, but look, 2 days later, she developed cerebellar edema, blocked the aqueduct, and developed hydrocephalus. So we had to put a temporary external ventricular drain. It took some days, and the cerebellar edema resolved spontaneously. We could remove the drain again. So this was one case. It's a typical complication that may happen if you close a significant petrosal vein, cerebellar edema. This is another case, petroclival meningioma, infrasupratentorial. with some edema of the brainstem. And you see here during surgery, we are approaching this petroclivar meningioma, glossopharyngeal nerve, 7 and 8 complex, and so on. Look at this. The petrosal vein was in between. I coagulated to enter this area. Today, I use a different technique. I work below and above this area. I go supracerebellar and avoid this division. Now, tumor is removed. Patient did very well. But 4 days after surgery, he developed a so-called peduncular hallucinosis. If you're not familiarized with that, this is a neurological condition produced also due to edema of midbrain and surrounding structures. This is a hyperexcitability of the lateral geniculate ganglion colliculus, and this produces these kind of changes. The patient is going to see geometric figures with many colors, and it takes some days and it resolves itself. But this is also a complication related to the petrosal vein. So because of some similar cases, we decided to study exactly the complications related to petrosal vein. We selected 59 cases of petrous apex meningiomas, and we checked the video recordings of all of them, outcome, and so on and so on, each case after the other. We could identify, in 2 cases, the vein could not be detected at the video, which is excluded from our study. In 27 patients, the vein was preserved. In 30 cases, the vein was sacrificed. And you see age, tumor size, and so on matched well. We found 1 single vein in 70% of the cases, 2 veins in 22, and more than 2 less frequently. And look at this. In the group where we preserved the vein, there was no single case of cerebellar edema, bleeding, peduncular hallucinosis, or something similar. And in 9 of the 30 patients where vein was sacrificed, we found these problems. Which problems were they? Most of them were related to transient edema of cerebellum with hydrocephalus. And this is one of the reasons people don't notice this problem. They ascribed this complication to spatula, but this is not spatula. This is a venous congestion. And in one case, the patient needed shunt, 1 peduncular hallucination, but look at this, 1 case of real cerebellar infarction. I will show you this case. Again, here where the vein was preserved, no complications like that. And in the other group, 30%, most of them, however, it was untransient. In just 5% of the cases, there was serious complication. Here, a case of the serious complication, but it's a very typical one. Also, petroclivar meningioma with extension into the bone, cavernous sinus, very infiltrative meningioma, young lady. We did a partial removal of this tumor. We want to remove this part and the other one put under observation or radiation. The patient did well, but at the same night at the intensive care unit, she was already extubated. She became comatose. We did a CT scan and we saw exactly this picture. This is a very typical picture of venous congestion produced by an important petrosal vein, which is sacrificed. And this is a very dramatic situation. You must go quickly, perform a decompression of posterior fossa, evacuate even cerebellar tissue. The patient remained weeks at intensive care. Finally, she improved. You see the tumor remnant under observation. she did well, but she has still some cerebral ataxia from this bleeding and surgery. But fortunately, she survived. The result of this retrospective study was sacrificing the petrosal vein, and I'm convinced of that, may produce complications in only 30% of the cases. And most of them are minor complications, transient complications. But be aware to these numbers here, you may have serious complication if you do systematically occlusion of the petrosal vein. And so we did a radiological study together with our group of neuroradiology, and this is a 3 Tesla MRI with MR angio 3D reconstruction. So if the patient has no tumor, you can see very well the petrosal vein, even in cases of microvascular decompression. Interesting is that in 22% of the cases, we couldn't find anastomosis. So these are the so-called dangerous cases. But really dangerous are these one. And very interesting, the correlation to our finding in this retrospective study. In 4.8% of the cases, there were no anastomosis, and the diameter of the petrosal vein was significant, so more than 2 millimeters. These are the cases we have to select and avoid occlusion if it's possible. We are now doing all studies with a tumor, at the presence of tumor, but this is more difficult to detect. So we have to continue our studies. So finally, question is, who had the truth? I think both gentlemen. It's correct that in most of cases, petrosal vein can be sacrificed, but you must pay attention because you do have cases where petrosal vein cannot be sacrificed and you can have terrible complications because of that. That means both are right. And this is the conclusion of our observations and our studies. Thank you very much for your attention.
Thank you so much, Marcos. Very interesting experience that you share with us. I have a few remarks. I don't know if the other have. If you have an injury to the vein, how do you handle that? Is it ended directly with the sacrifice, or if you have some tips and tricks to still preserve the vein?
So if I have a small injury, and then I put gel foam and fibrin glue on that area. So I try to avoid to close the vein. So just put fibrin glue on this area. And if the patient is in sitting position, I ask for jugular compression to have blood within the vein. And I put gel foam and fibrin glue. It works. The problem is when you have a complete rupture, it's impossible to reconstruct. So what I do is I inform my colleagues at the intensive care unit. This is a patient where the vein could not be preserved. Be aware, he might deteriorate at night. In most of cases, nothing happens, as our study has shown, but you will have, if you do this systematically, you will have the cases with complications.
You nicely show also how to make the vein more free by dissecting the arachnoid distally. I have heard about surgeons who place a small glue point preventively just at the junction between the vein and the petrosal sinus. Yeah. Do you have any comment on that?
Yes, sometimes I do that because when we start surgery, we see there is some bleeding at that part, or the anesthesiologist is saying there is some air embolism, so very small bubbles, and then we put fibrin glue. You can reinforce the vein at this critical area. This is the area where the vein is entering the superior petrosal sinus. This is exactly a critical area. But of course, you cannot put a lot of glue everywhere. You have to remove your tumor. But one I told at the beginning, and this is for me the most important implication of this, when you enter the posterior fossa, try to go from below to above. And when you go with your spatula, you must go from below to above, because at the inferior part of the cerebellopontine angle, there is no important veins. But the superior part of the cerebellopontine angle, the superior part is narrow because of the vein. So you do your retraction from below to above, and the spatula is turned in such a way that it opens at the inferior part more than at the superior part.
Thank you for this trick. Another question I read, if you want to sacrifice a vein with several branches, which branch will you preserve absolutely?
Yeah, we have had such a case. So I had a case of trigeminal neuralgia where the vein was the cause. So I learned this trick from the Japanese colleagues. I put a temporary clip on the vein and I wait some minutes for the auditory evoked potential. The auditory evoked potential is very sensitive. If you have edema of this area, you have a decrease of the auditory evoked potential. If the potentials remain absolutely stable after 5-10 minutes, then this is a good sign that you may sacrifice this vein. Yeah.
I still learned something from you, Marcos. Thank you so much. Very interesting to know that. Very interesting. Thank you so much. And I can read that there are many people who congratulate you for your talk. Thank you. Have you any other question from the others?
Yeah, I have a short question. In the petroclavian meningiomas, I see frequently that the petrosal vein is completely compressed, and only if you dissect the tumor, you see it starts to fill. So I would imagine if you sacrifice that vein, there are already collaterals. This is different to microvascular decompression, where the veins are always intact, and then the danger is much higher.
I think you are right. You are right. But you saw, I showed, that's the reason I showed exactly cases of Petrous apex meningiomas, where we had one cerebellar edema in one case and one terrible complication in the other case. So it's true what you say. Probably there are more collaterals when you have a tumor, but this is not a guarantee.
Yeah, sure. I completely agree. We should preserve the vein in all cases if possible. Sure.
So, Henri, Professor Schroeder, it's just time to you to share with us your experience on the complications and how to handle this complication during macrovascular decompression for hemifascial spasm. And please, up to you.
Miguel, thank you again for the invitation to participate to this webinar. And I restrict myself to hemifacial spasm because I saw I will need too much time to explain all the complications, what I have seen. So of course, you have heard already, prevention is better than treatment. And that is very important when you plan your surgery for hemifacial spasm. A lot of precautions should be taken. At first is you need a precise imaging to see all the compressions. Frequently, I saw cases where the first surgeon missed a vessel which is far down in the pontomedullary sulcus. And if you would look precisely at the imaging, then you can see this already before you start with the surgery. And we use the CIS sequence and the TOF for all the cases. What we do is supine position of the patient. We turn the head to the contralateral side and we make an inferior retrosigmoid approach. It's just a small approach, but it should be flush with the skull base. So we do not use any retractors, but just by gravity, we have a good retraction of the cerebellum, which prevents also complication. And we use endoscopy in all of the cases. And the best to see the compression side is a 45-degree endoscope. So the positioning, you see the rotation of the head is not 90 degree or 80 degree, it's just 45 degree. And then we rotate the whole table to have a better view to the surgical field. And we have, of course, monitoring of acoustic awake potentials and facial nerve for the lateral spread recording, what you see here. And then ideally after the decompression, you see a complete disappearance of the lateral spreads. So there is a nice meta-analysis of Marc Sandou about microvascular decompression for hemifacial spasm published in 2017. And he found a lot of studies dealing with complications and put that together and showed that the microvascular decompression for hemifacial spasm is quite a safe operation. Facial palsy 1 to 2%, recurrence 2 to 4%, loss of hearing 2 to 3%, lower cranial nerve problems up to 1%, CSF leakage, stroke, but also mortality. And another paper from Machitsami showed also that the results are good and mortality is 0.7%, hearing loss, the most frequent problem, and also vertigo. And I would like to present the complications, what we have seen in our series of hemifacial spasm, decompression. We have 458 surgical procedures and 431 patients. Some of them needed 2 surgeries and 2 patients required 3 surgeries. Most of the patients were females, mean age was 55 years, duration of symptoms for almost 8 years. And left-sided, mostly, most compression on the left side. And you see there's a variety of offending patterns. The pike and Ica are the most frequently offending vessels, but also a combination of all of these. Venous compression is very rare. We had just 1 case with only venous compression. And we had 2 very interesting cases. There was no vessels causing compression, but arachnoid bands, which strangulate the nerve at the exit zone. And the results are usually good. We have 56% immediate spasm resolution immediately after surgery. And then you see over the years, the number is increasing. And at 18 months, we have about 90% very good results after decompression. So one problem is recurrence. Why do we see recurrence? So one example, you see clearly a compression of the facial nerve by an Ica loop. We decompress this with a Teflon, shredded Teflon, put it in between, and it looks very nice after surgery. Initially, she had an improvement, but then later on it came back, almost in the same intensity like before. So we make a revision and we looked in, you see here, there is a Teflon in place and there is no contact between a vessel and the nerve, but still there's a problem. So what we do in these cases is that we completely remove the Teflon. We completely remove, this is the facial nerve down to the pontomedullary sulcus, and in the area of the nerve, all Teflon is removed and we just leave it before and behind the facial nerve. And then the spasm went away completely. So there are some facial nerves which seem to be very vulnerable, even to the contact to Teflon. And this is our series of revisions. So we had 25 patients where we made a revision surgery, and we see we have really a marked improvement in 18% of them. We have also cases with new improvement, and these were the cases where the nerve has already really an indentation, so a structural damage. And then, of course, it's difficult to get a good outcome. So that's why where should be the Teflon positioned? You see here is the vertebral artery compressing the pica loop against the facial nerve, the tandem compression type. And what we do is we put some Teflon in front of the nerve and one in the back, so that the compression zone is free of Teflon contact. And this really improves the results, obviously. The most common compression, what we see is, of course, CSF fistula. The occurrence is sometimes very early after surgery, sometimes late, even after 3 weeks when the patients were already sent home. And we could deal with it with a lumbar drainage in 6 cases, but in 6 patients, we had to make a revision. What is the reason for the fistula? Usually, it is a very thin dura, which could not be sutured in a watertight fashion, and a very well pneumatized mastoid. Sometimes you have really a big hole in the mastoid, and you know you have to take muscle or fat to put it into the cavities and then fibrin glue to fix it. But sometimes you know when you close it that there's a high risk of CSF leakage, and then in these cases we could also add immediately a lumbar drainage to prevent this complication. But sometimes it's really difficult, especially if you have obese people, big pneumatized mastoids, and you know it's a high risk for CSF leakage. And we are very accurate in the occlusion of these open air cells. We put muscle in the air cells, and then we put another layer of muscle on the air cells, and then we fix it with fibrin glue. Facial palsy is, of course, a typical complication because you have to handle the facial nerve. And we have an immediate facial palsy in 10 of the patients. And this is because of manipulations. You see sometimes it's a minor degree, but it can be also very high degree. And if you see this megadolichovertebral artery and you see the facial nerve is here displaced laterally, and you see that it's a calcified vessel in older patients, and you know that is a problem. You see the video of the patient, you see this is 8, this is 7. It's a huge vessel. It's only a minor space to mobilize it, because here's already the skull base. And then of course you have to retract the facial nerve a little bit. And then we put some Teflon between vertebral artery and brainstem, and then also between the Eicher loop and the brainstem. Of course, you have some manipulations here. Finally, you see the facial nerve is free. And he has also a resolution of the spasm, but he had a complete facial palsy. The good thing is, all the palsies which we have because of manipulation, usually they improve to grade 1. That means normal, or grade 2. And we had just one patient with a grade 3 facial palsy after extensive manipulations. This is a patient where we required 3 surgeries because of this large calcified vessel. Much more typical is a late facial palsy, which occurs usually at day 10 or 11 after surgery. And the good thing in these kind of palsy is that they usually go away after weeks, sometimes even months. And the reason for this is not very well understood. Some people say it's an activation of herpes viruses within the nerve. We always advocate for lumbar puncture for academic interests to see is there a PCR for herpes simplex viruses. And people who do it or did it, in these cases, we did not found any increased indication of herpes in the CSF. So it may be another reason. Some people say it's vasospasm, but I don't think so because it's too late after surgery. I think it must be a viral origin. But the good thing is with a very good resolution in the long-term follow-up. Another problem is, of course, lower cranial nerve deficits, because you have to manipulate in some patients the lower cranial nerve group to get access to the compression point. This is one example. This is a 47-year-old male. He had a left side hemifacial spasm for 7 years. She got a lot of Botox injections. But when he came initially, I thought it is not a hemifacial spasm, but it is a kind of facial dystonia, because the tonic component of the spasm is so prominent. Only rare you see this clonic contraction of the facial muscle. So I thought initially it is a dystonia, but then after a while you see these contractions. And if you look at the MRI, you see the pica loop is going far up into the brainstem. So we make the surgery. At first, we cut the dura over the lower cranial nerve. So surgery for hemifacial spasm is surgery for lower cranial nerve group. It's not a surgery for the facial nerve, but the compression is always far down. You see here, this is the 9th nerve. So we see with the microscope, not the compression side. So we take a 45-degree endoscope, and you see as the pontomedullary sulcus, and you see the vessel loop goes here into the brainstem, causing the compression exactly where the facial nerve has his exit zone. So I tried to dissect below the lower cranial nerves. You see, I have to manipulate it. Here's the origin of pica, indicated by the loop of a hypoglossal fiber around the pica origin. Then I look with the endoscope again, but nothing changed. So I was thinking what to do now. So I go back again down here. And I was very brave to mobilize the pica now. And then I put some Teflon between the brainstem and the proximal pica to prevent that it slips back again. And then I went over the lower cranial nerve group, and then I could take my dissector and pull the loop out of the brainstem. But this was very tricky and a lot of manipulations to the lower cranial nerves. And then after surgery, he had hoarseness, of course. He had a little bit improvement. And only after 4 months, the spasm went away completely. And after 6 months, his hoarseness resolved completely. And this is after surgery, he completely cured from hemifacial spasm. But a lot of manipulations, of course, can cause a problem. So what can we do better when we have this problem again? You see here again, the pica loop within the brainstem looks almost the same like in this patient. And in this case, we fixed an endoscope to the holding arm. So I had the ability to dissect under view of a 45-degree endoscope. So with a microscope, you see, it's the same like in the other patient. I could not see, although I retract the cerebellum, I could not see the compression point. Then I took a 45-degree endoscope. You see a vertebral artery here. Again, pica origin. Here's a branch of the hypoglossal nerve indicating this is a pica origin, compressing the facial nerve. And then under the view of a 45-degree endoscope with less retraction, with a curved dissector, I could take the loop out of the brainstem and mobilize it away. And then I put some shredded Teflon between the bezel and the brainstem to keep this position. I think this is a kind of measurement to avoid these manipulations of the lower cranial nerve group. Perforator infarction. Fortunately, we had never one patient where we injured a major vessel, which was the offending vessel. This does not occur in our series, but we had one perforator problem. You see again, a lady with left-sided hemifacial spasm. You see the vertebral artery, and here's a pica compressing the facial nerve. When we look with the endoscope, you see here vertebral artery, pica origin, and here again a branch of the hypoglossal fiber. So we mobilize it. You see here is a perforator. I mobilize the vessel, but I know when I put just Teflon in between, there's too much compression. So in these cases, I use a sling technique. It's a Gore-Tex sling, which is placed around the vertebral. And then I create a pocket in the dura between the jugular foramen and internal auditory canal, and then I place it clip. And then we look in again. Looks very good. The vertebral is close to the skull base, so I just had to decompress the pica. Put it in. Everything looks good. Potentials were fine. No change. And then after surgery, when I visit her, she had hoarseness, swallowing problems, and balance problems. We made, of course, immediate MRI. And you see here an infarction in the brainstem. And after 6 months, fortunately, he had recovered very well. So he had no problems with swallowing, no hoarseness. She had a little bit balance problems, but not much. So she is able to walk, and she's still happy with me that the spasm is gone. But I think this is a complication, of course, we have to avoid. And if you look to the perforator here, you see it's very well perfused. And then when I place my sling, the perforator is not perfused. I did not recognize this. I did not take care. So this was clearly my fault. There was no, the origin of the perforator was not within the sling, but because of the compression of the vessel due to the sling, it was not perfused. And that, of course, should not happen. How can we avoid this? Another patient, you see compression here, vertebral artery again, and also the pica loop. You look again, see here the vertebral artery, very prominent vessel, very thick. And then smaller branch. I always look, is there any perforator behind the vertebral? You see the compression, this is the facial nerve, this is the vestibular cochlear nerve. So the vessel is dissected. And then I mobilize the vertebra, and you see there's a lot of pressure. When you just place shredded Teflon in between, that would not be sufficient, I guess. So again, I take this Gore-Tex sling, bring it in, take it out, and then with 2 forceps, it is pulled laterally to the skull base. Then I create again a pocket here in between jugular foramen and internal arterial canal, and then I fix it with the aneurysm clip. Clip is better than suture because I can adjust it. You see now the perforator looks not well perfused. You see it's a very delayed filling of the perforator. Here the pica comes very early, so I release it a little bit, fix the clip again, and then I make another angiography, and now you see how nicely the perforator is filling immediately, same time like the pica here. So I think with the angiography, you can overcome the problem with the perforator. Sometimes it's not possible to make a sling technique. Just in a case last week, we had 3 perforators exactly in the area where I could place the sling. And then of course you cannot do it. Then you have just to place Teflon in between the vertebral artery and the brainstem away from the origin of the facial nerve. So I did 46 MVDs with a sling technique, and one of them had this complication because I did not take care of the perforator, a complication rate of 2.2%. Then we had another patient with a compression. He had already 2 previous MVDs at another institution. You see here the compression. Again, a very prominent vertebral artery. We made the surgery, went very well. After surgery, he was doing fine. And then in the night, he developed myocardial infarction. He was brought to the cardiologist. They make an intervention with stenting, and then they requested that they need dual antiplatelet therapy. And of course, you know what then happens. It was a recurrent case. We had to dissect a lot through scar tissue. He bled into the 4th ventricle, into the area, and you see here. And then he developed hydrocephalus. He needed an EVD. Then he slowly was recovering after 3 months, and he was sent to rehabilitation unit, and he came within malabsorptive hydrocephalus. He needed a shunt, and he visited me after 2 years, and he was still happy with his hemifacial spasm, although he has this journey and this course after surgery. So this also may happen. Of course, we cannot for 100% prevent these events in the post-op period. And finally, I would like to present my disaster case. This was a lady with a left-sided hemifacial spasm. We did the surgery. You see a facial nerve. You see the compression. We dissect here. This is an ICA loop. Here you see the facial nerve. See, here's the vertebral artery. On the left side is the right hypoplastic vertebral. So per definition, this is the ICA loop. Compressing it, we put the Teflon in between, and she was okay. She left our hospital 5 days after surgery, and then she arrived home. And on the 7th day, she complained of a headache, vomiting, and she did not feel good. So the daughter called me. I said, yes, she must be a post-operative meningitis. She has to go to a local neurosurgical department for further care. And she went to another institution. She was admitted, and they saw CT looks good. A little bit dilation of the ventricles. So they put an external ventricular drain. They checked for bacteria, and they found some streptococci, and they treated with antibiotics, but it was not in the culture, it was just in the initial investigation by microscope. So obviously it was not an infection in the CSF, but taken from the puncture. And then she deteriorated further and she had a seizure. And then they made a lumbar puncture again and looked for herpes virus, and they found that there's an increased herpes simplex encephalitis. But you know, if you do not start at the beginning of the disease, you have no chance to treat it. So she had this severe hemorrhage, severe swelling. They made a bilateral decompression, but unfortunately, the lady died 21 days after surgery. So this was really a disaster. And the colleagues at this institution looked to the literature and they found an incidence of 1 activation of herpes encephalitis and 20,000 craniotomies. So I don't know whether one of you have experience with this, but that of course is a very, very sad cause. So if you take our complications together, 431 patients, we had 0.7% meningitis, 2.8% CSF fistula. Hearing loss was mainly caused by some open air cells and water in the ear. Facial palsy, 8.4%, usually delayed, only a few one immediately after surgery. Vertigo and 2.6%, and lower cranial nerve problems 3.5%. In the long term, we have this one mortality because of encephalitis. We have patients with decreased hearing but useful hearing, and we have 3% of patients with hearing loss, 1% vertigo, 1% with facial palsy, Haus-Brackmann 2 or 3, and hoarseness in 1 patient. So my conclusion is that the microvalvular decompression for hemifacial spasm is in generally a safe surgical technique. Important to me is supine position, has less complications than the sitting position. I think Marcus will agree that for hemifacial spasm it's not required to have a sitting position. Careful sharp dissection is required. The infrafloccular approach is very useful to avoid traction to the cochlear nerve and has better outcome regarding hearing. We don't use any retractors. Monitoring is of course mandatory, and special technique, special attention should be taken when you use a sling technique because the small perforators are at risk. Thank you for your attention.
Thank you so much, Henry, for sharing with us your impressive experience on this topic. Time is a little running now, so I propose to move to the other topic, the management of the complication during endoscopic transsphenoidal surgeries. It's already difficult to manage arterial injury during transcranial approach, and I'm very interested to know how those are handled through endoscopic transsphenoidal approaches. So we will move to listen to the talk of Julia Kozu from Lausanne on the risk factor for vascular injury during those approaches. Please, Julia.
Julia, you're on mute.
Can you hear me now?
Yes, we can hear you.
So good evening, everyone. Thank you for the opportunity to be here and speak about the risk factors associated with the vascular complications after endoscopic endonasal procedures. So you all know that when you work in the sella turcica, your working corridor is limited laterally by the intracavernous portion of the ICA. And when you perform endoscopic, extended endoscopic endonasal approaches, you can also expose the paraclival ICA or through the transtubercular approaches, the supraclinoid portion of the ICA, as well as the anterior communicating complex. So the risk of an ICA injury is not so remote in your clinical practice, and you have to remember that it can be a life-threatening complication, of course, and it is in most of cases unexpected, as tumors may displace cranial nerves and vessels, and you have to be ready to manage this kind of complication. It was reported to be between 0.2 and 2% in large surgical series. So which are the risk factors that may be associated with a higher risk of ICA injury during your endonasal procedure? You have to consider the location of the lesion. So you know that there are some tumors that may extend beyond the limits of your sella, so inside the cavernous sinus or even more lateral into the temporal fossa. You have to consider the nature of the lesion that you're treating. So beside pituitary adenomas, you have to treat sometimes chondroid tumors that may have a more aggressive behavior. Then you have to consider the anatomical variations of your patients in terms of bony anatomy, so your classical landmarks that you will use during your endoscopic approaches, as well as the vascular anatomy of your patients. And then the last factor is your surgical experience that may, of course, influence the rate of vessel injury. So the first factor, you may have tumors that may invade the cavernous sinus or even extend more laterally into the temporal fossa or superiorly inside the suprasellar space, as well as into the subarachnoidal space, thus provoking an encasement of the ICA or of the anterior communicating complex. Then tumors may also extend inferiorly and provoke an erosion of the skull base and thus disrupt all the common landmarks that you're used to do. This is a classical example of an ACTH secreting pituitary adenoma that we were treating, and after the resection of the intracellular portion of the tumor, we were working inside the cavernous sinus on the right side because the tumor was showing an invasion of that of the cavernous sinus on that side, and we were working behind the carotid. This is the intracavernous portion of the carotid that you can see here, with suction and curette. And you have to remember that an injury of the ICA may also be provoked with blunt instruments. So extended approaches may be associated with a higher risk of ICA injury because you will expose multiple segments of the ICA, and like Gardner reported in this series, transclival and transpterygoid approaches are associated with a higher risk of ICA injury when compared to series where only pituitary adenomas were treated. The nature of the tumor, typically chondroid tumors may be associated with a higher risk of ICA, again, because they may extend into various compartments. So you will perform extended approaches in this case, and also because they may displace or they may narrow or even infiltrate the ICA in some cases. So this is a case that we treated at our institution of a chondrosarcoma, and we decided to perform a transpterygoid approach. So the patient presented with a left 6 cranial nerve palsy, and the MR showed this lesion that was centered inside the sphenoid sinus and on the left pterygopalatine fossa, that had an heterogeneous contrast enhancement, and the bony CT showed that there was a large erosion of the skull base, thus with disruption of all the common landmarks that we use. Also, the medial nerve was no more identifiable, a landmark that in general we use to localize the paraclival ICA. So we started the procedure with the opening of the bullet moidalis to enter into the maxillary sinus, and then we exposed the rostrum to enter also to perform a large sphenoidotomy and to be able to expose the tumor. So here you can see the tumor that is extending inside the lateral portion of the sphenoid sinus. Then here, this is the projection of the paraclival ICA, and then there was also a component of the tumor that was extending more lateral. So we started our resection addressing the more medial portion of the tumor. That was the safest one. With electrocautery and dissectors, we could perform a safe piecemeal resection. And once that we completed that step, we addressed the lateral portion of the tumor that was even lateral to the ICA. The ICA was localized thanks to the neuronavigation and to the Doppler ultrasound, because it was not possible to recognize it because of the presence of the tumor. And then the last portion that we treated was the one extending into the cavernous sinus. So we opened the floor of the cavernous sinus, and then we dissected this portion while stimulating for the cranial nerves. So at the end of the procedure, this was the vision that we had. We could recognize again the sella turcica, the claval recess, and then the paraclaval ICA. And the postoperative MR showed also a good result with a small residual tumor inside the cavernous sinus. This was another challenging lesion. The patient was a young man that presented with a left 6 cranial nerve palsy again, and the MR showed this lesion that was entirely extending into the left cavernous sinus. It was a cavernous sinus hemangioma. So again, on that case, we performed a classical transsphenoidal approach, a little bit more lateralized on the left than what we are used to do. Also, the dura was open just on the left, and the normal pituitary was medialized to avoid any injury. So here we started with the tumor dissection. We coagulated the tumor to have a shrink and to be able to perform a piecemeal resection. And once that the more medial portion of the tumor was out, we started with the more lateral one, really inside the cavernous sinus. And once that also this second part was out, we were able to work really behind the carotid with the curette and the suction. So this was the intracavernous portion of the ICA, and we were able to perform a complete resection also of that part. The patient completely recovered from his palsy, and the postoperative MR showed that there was no more residual tumor. So you have to consider that the risk of injuring the ICA may also be different according to the subtype of pituitary adenoma that you will treat. For instance, Cushing disease is associated with hypertension and atherosclerosis, so you will have to deal with more rigid vessels that can be more prone to rupture or to lesion, even with blunt instrument when they are mobilized. And then the other classical example is acromegaly, when you have anatomical changes in the nasal cavities and also into your vessel with the typical morphology of kissing arteries like this shown in this axial MR, where the space between the two internal carotids is very narrow. So the anatomical variations of your patient include variation in the vasculature, in the cerebral vasculature. So in this case, this is another GH secreting pituitary adenoma with this angio-CT that showed a very narrow corridor where we could treat. And this is the intraoperative view. So we already took out the GH secreting adenoma. This is the cella where we were working. This is the opening of the cellar floor, and inside the cella we could already see the two carotids on the left side and on the right side. So we had barely the space to put a small curette to work in this dangerous space. The other factor that you have to consider is if your patient had previous surgery. So in that case, you can have a disruption of the normal anatomy. This was a case of a GH pituitary adenoma that was operated, but the patient didn't reach a surgical cure, and the follow-up MR showed a residual tumor that was localized into the right cavernous sinus and in the retrocarotid space. So we knew when we started again, when we started a second surgery for this patient, that we had a modified anatomy because the landmarks were already destroyed during the previous surgery, and then that we had a lot of scar and fibrosis to face, and that we had to work behind the carotid. The last factor, but it is not less important, is the intraoperative experience of the surgeon. So this is an old paper published more than 20 years back, but it is still up to date because it showed that the rate of ICA injury was inversely proportional to the experience of the surgeon. So if you compare the number of transphenodal surgeries that were performed, the risk reduced to 1/4 when you perform more than 500 surgeries per year. The most frequent injuries are ICA rupture and hemorrhage and pseudoaneurysm, but you can have more rarely also the formation of carotido-cavernous fistula. Some vascular injuries may be directly visible during surgery with a massive bleeding that can be difficult to control. So the most important thing is try not to panic and try to manage your complication. Or in other cases, your complications may not be directly evident during surgery, so they can be underestimated. And an important advice is to perform a diagnostic angiography whenever an ICA injury is suspected, like in that case where we saw a carotido-cavernous fistula on the left side after a transphenodal procedure. So in our surgical series in Lausanne, where we treated more than 500 cases of pituitary adenomas, we had 2 cases of ICA injuries, so with a rate that was comparable to what reported in literature. And we had 1 case of carotido-cavernous fistula and 1 ICA rupture. So our first case was a 74-year-old lady with acromegaly, and the MR was showing a micro GH secreting pituitary adenoma that was extending into the left cavernous sinus. We performed an uncomplicated transphenodal surgery, but we had a copious bleeding from the left cavernous sinus. So the patient was discharged, everything was fine, but 1 month after surgery, she came back presenting with persistent pulsatile tinnitus, and the emergency angiography showed a direct fistula between the carotids and the cavernous sinus, as it is also depicted here in the 3D reconstruction. So she was treated by our team of neuroradiologists with transarterial and transvenous coiling, and at the end of the procedure there was no more communication within the carotid and the cavernous sinus. We also performed a literature review, and we saw that it was a very rare complication, as it was reported only in 9 other cases after transphenodal procedures performed for pituitary adenomas or more aggressive tumors. Our second case was a young man that came with a pituitary apoplexia and a right 6 cranial nerve palsy. So these were the images with the tumor extending into the right cavernous sinus. We started with an endoscopic procedure, a classical one, a transphenodal one, and we were exposing the rostrum as usual. Here it is with the 2 sphenoidal ostia. And we were used at that time to open the rostrum with the osteotome. But while we were performing the cut on the right side, we provoked a fracture that extended posteriorly till the cavernous sinus and anterior genu of the carotid, and we had a massive bleeding. So the most important at that moment, even if it is difficult, it is not to panic. You have to try to manage the hemorrhage. If it is possible, you have to find a source of bleeding. And anyway, you have to try to pack with hemostatic material and mechanical compression. So here we were trying to manage the hemorrhage. It was not easy. We had to find a good position for the cottonoids to be able to control the hemorrhage. And here we were able to stop the hemorrhage and to bring the patient in the emergency arteriography room. So these were the images. we performed an emergent angiography that showed that there was a direct communication between the carotid and the cavernous sinus, and the patient was treated with transarterial coiling to stop the bleeding. So we were able to preserve the patency of the ICA, even if we had a big discussion because our neuroradiologists weren't sure to be able to control the hemorrhage only with coiling, but at the end they succeed. So the patient had no new neurological deficits, and we postponed the treatment of his pituitary adenoma. What we learned from that case, we stopped using the osteotomy for performing the osteotomy, and now we are gently drilling the rostrum to join the two ostia to avoid any complicated fracture. So what do we have to remember? That prevention is of course the best management, but it is not always possible to prevent. You shouldn't underestimate your surgery, even if you have a good experience. The preoperative analysis of the vascular anatomy of your patient is extremely important to perform a safe procedure. And whenever an ICA injury is suspected, you have to perform an emergency diagnostic angiography. Besides that, a teamwork with the neuroradiologist is mandatory to grant a good outcome to your patient. Thank you.
Thank you so much, Dr. Kozu, for your nice talk and sharing with us your experience, the Lausanne experience. I will suggest to maybe concentrate the discussion at the end of the 3 topics concerning the endoscopic transsphenoidal approach, and we will move on directly to listen to the talk of Monsef Beruma, which is a talk focusing on the same topic, the vascular injury during this approach. Please, Monsef, up to you.
Thank you, Michael. Do you hear me?
Yes, perfectly.
Okay. Thank you, Michael, for involving me. My talk will naturally follow the former presentation from Julia, and I propose to discuss with you the management of ICA injuries during endoscopic endonasal approaches. As already said, ICA injury is one of the most feared intraoperative complications. The incidence, as it has been said, is between 0.2 to 2% for standard pituitary approaches, simple ones, but maybe more important in extended approaches with some series reporting up to 9% of carotid injuries. As you will see, the interventional neuroradiologist plays a predominant role in this management, but as the published series remain rare, there is not sufficient data to propose at this point any evidence-based protocol for the management. For this presentation, I will distinguish 3 phases in the management of ICA injuries. The pre-operative evaluation that may help identifying the patients with a higher risk of injury, then the intraoperative crisis management itself, and finally, we will discuss the post-operative follow-up of these patients. So let's begin with the pre-operative evaluations. Many points have already been described in the former presentation, so we'll go through very quickly. This evaluation is based on factors related to the specific anatomy of a patient, factors related to the tumor itself, and factors related to the patient directly. Concerning the anatomical factors, it is important to keep in mind that in up to 22% of the cases, the lateral sphenoid wall may in fact be dehiscent with only dura and sphenoid sinus mucosa overlying the ICA. So be careful with the grasping forceps, for example, to take out any bone or mucosa at that point. The distance between the ICA and the midline is also very important to be precisely evaluated on CT and MRI. As you can see in this MRI, this distance between the 2 ICAs can be as short as 2 to 1 millimeter, especially in acromegalic patients. Very frequently, sphenoid septations also attach to the carotid canal, and care must be taken when removing those septa. And one should prefer drilling with a diamond drill those septa instead of taking them with a grasping forceps. Finally, do not forget cavernous ICA aneurysm which represent up to 12% of all intracranial aneurysm, with some reports showing an association with pituitary adenoma. So let's identify them on the pre-op imaging. Vessel encasement by the tumor itself has been detailed, and not only injury may be caused by the tumor resection, but also vasospasm by only manipulating the tumor. So we should be careful with that also. Patient evaluation is also a very important. Associations between ICA injuries and specific conditions have been nicely described. Radiotherapy, bromocriptine therapy is also a risk factor. Revision surgery and acromegalic patients, as we said already. So let's move to the intra-op crisis management itself. ICA rupture represents one of the most challenging situations for the neurosurgeon. It is a high pressure arterial flow in a very limited anatomical space, which is namely the sphenoid sinus. So before attempting any hemostasis, the surgical team should control the surgical field, namely. So leading the team and the communication with the other persons inside the room, trying to stay calm. It's easy to say, not so easy to practice when you have that in face of you. And using a forehand technique with 2 suctions and a lens cleaning will facilitate the management of the bleeding. During this phase, every single person in the room should know exactly what she has to do. So the anesthesiologist knows what he has to do, the resident, the scrub nurse, and there is no place for panic in these cases. So this is something that we learn with the experience. At the end, we know there's no place for panic in those cases. Nasal packing represent the mainstay of intraoperative management, as Julia said. Several packing agents have been described in the literature: Teflon, gel foam, hemostatic agents, Surgicel, but gauze remains the most frequently used because of its availability on the surgical table. This packing must be very well controlled to avoid overpacking that may lead to carotid occlusion or stenosis itself, and may lead also to cranial nerve compression. Nasal packing is of course not recommended if the dura, when the dura is open, unless the bleeding will occur intracranially and will not be seen by the endoscope. There are some adjunct maneuvers that may also help clearing the field. Cervical carotid compression has been used in some series, uni or bilateral. Adenosine has also been described, like in aneurysm surgery, to decrease dramatically the pressure, the blood pressure, eventually provoke a heart arrest. While head elevation and hypotension are not useful and may be very harmful by decreasing the cerebral blood flow in this case. Third thing to control the surgical feed is a muscle patch. It has been proven to be an excellent hemostatic adjunct when possible, when the bleeding is controlled, of course. Different graft sites are possible, including locally. It has been described with the longus capitis muscle in the cavum. According to some authors, the graft may also reduce the risk of evolution toward the pseudoaneurysm and carotid stenosis at long term. So it is very useful. This muscle graft should be applied securely on the carotid injury site for about 10 to 15 minutes, and then reinforced by Surgicel and ideally by a nasoseptal flap to avoid any contact of the air with the carotid and the muscle patch. Whenever possible, when the surgical field is controlled and the carotid artery is sufficiently exposed before the injury, a direct control of the vessel injury may be attempted. It's not easy to see the defect, and usually we only pack it emergently, but when we can see that the injury, we can eventually, at least some authors have described a direct control of the vessel with different means: direct suture of the artery, U-clip made by Medtronic, but not commercially available actually, aneurysm clip, which lowers the risk of pseudoaneurysm evolution, but increases the risk of carotid stenosis. Sometimes bipolar electrocauterization may be useful and tried, but the risk is to enlarge the vessel defect, and the risk of vessel stenosis, of course, if the intensity of electrocauterization is too high. And finally, the endovascular treatment will come. As we said, once the hemostasis is obtained, the patient should go immediately to the angio suite or a hybrid room if you have one in your surgical rooms. And there are 3 types of modalities for the endovascular treatment. The most common one is the ICA occlusion. It's the most easy, it's straightforward, it's done in a few minutes, and it controls immediately the bleeding. Usually it is done immediately by the neuroradiologist when hemostasis, surgical hemostasis is not optimal when getting out of the operating room, which is rare. Occlusion is generally obtained using a balloon or coils and should be performed at the wall defect exactly to prevent any extravasation of blood from both anterograde and retrograde vessel filling. With this emergency occlusion of the ICA, the risk of stroke reaches 21% of permanent deficit. So the morbidity is relatively high. In a review of ICA injuries treated by occlusion, mortality was even evaluated to 6.5%. When time permits, when hemostasis is optimal, assessment of collateral perfusion is recommended before occluding the carotid by doing a balloon occlusion test. Keeping in mind, of course, that in these balloon occlusion tests, even the patient who passed positively the balloon occlusion test, there are 4% of patients that may develop a permanent stroke. So be careful with the results of those tests. And only there are very rare cases have been described where a bypass has been proposed before ICA sacrifice when the hemostasis is obtained. Second mean for the endovascular surgeon is the endoluminal reconstruction to preserve the vessel. Usually it's a stent graft used, technically challenging because of the tortuosity of the cavernous carotid, as you can see here, and the necessity of usually dual antiplatelet therapy. So stent grafts are associated with a high risk of stent migration, thrombosis, and vasospasm. And despite antiplatelet therapy, as we have seen in the case presented by Professor Roche, there is quite 4 to 5% risk of stroke within the first month of stent placement. Other devices are actually used also to preserve the artery that are flow diversion techniques, but long-term follow-up is lacking because of the rarity of the disease, and we don't have a large series of flow diversion techniques in those ICA injuries caused by endoscopic endonasal approaches. The last modality of treatment that can be discussed in those cases is the occlusion of the lesion itself. I mean, occlusion of the pseudoaneurysm, which is the coiling of the pseudoaneurysm. Unfortunately, the results are poor for this technique, if not associated with the stent, because there is a high risk of recurrence. That the pseudoaneurysm doesn't have any proper wall, so the coils will be pushed within the sphenoid sinus, and there is a high risk of recurrence and dramatic epistaxis sometimes. Concerning the postoperative management, the monitoring in ICU is mandatory with the packing in place. If the immediate angiogram is normal, usually we repeat it at 1 week before unpacking the patient. Then we repeat it at 6 weeks, 3 months, and 1 year. This is one of the most frequent protocol used for those for the detection of pseudoaneurysm, as they can appear lately after the injury. If a pseudoaneurysm is detected at this stage, a few days or a few weeks or a few months after the injury, we have 3 therapeutic options available. The coiling, as I said, but there is a high risk of recurrence. It's not the first choice, actually. The surgery, the bypass surgery, but or aneurysm clipping, pseudoaneurysm clipping, but there is a high rate of complication in the literature. And actually the gold standard for these pseudoaneurysm is a covered stent or coiling, stent-assisted coiling that gives the best results, long-term results. Actually, there is no consensus concerning the best endovascular management in ICA injuries. In a recent paper by Sylvester, the author reviewed all published ICA injuries during endoscopic endonasal approaches and he gathered more than 100 cases, focusing on the type of endovascular management used in these cases. ICA occlusion, as you can see, sacrifice was the most frequently performed. So roughly 45% of the cases were occlusion of the ICA, followed by endoluminal reconstruction and lastly lesion embolization. During the last decade, there is clearly a trend toward, as you can see, there is clearly a trend toward an increasing rate of endoluminal reconstruction. It's the yellow curve against the blue curve, which is the occlusion of the ICA. So many people are moving, changing paradigm from ICA occlusion to more endoluminal reconstruction with graft stent and flow diversion. If we detail the endovascular treatment type according to the type of injury, you can notice that for pseudoaneurysm that are in green color bars, all modalities of treatment have been described. There is a large panel of modalities, endovascular modalities. While for active bleeding, which is the blue bar, only ICA sacrifice and covered stents appear effective and are practiced in a daily routine. Concerning the morbidity, you see that ICA sacrifice remain the riskiest procedure with a risk incidence of permanent deficits reaching about 20%. So simple coiling of a pseudoaneurysm, on the other hand, appears very safe, but have a high risk of recurrence and progression and is not routinely used actually. The endovascular have abandoned this technique for pseudoaneurysm. Actually, you find in the literature several algorithms have been proposed to manage this rare complication, rare and dramatic complication. Roughly, we can consider two situations after the immediate angiography at the exit of the surgical room. Either the carotid appears intact, or there is a pseudoaneurysm, a carotid cavernous fistula, or an active extravasation seen during the angiography. In the case of an intact vessel, as I said, the patient should remain in the ICU with his packing in place, and an angiogram is repeated at day 7 before the removal of the packing. Ideally, the removal of the packing should be done in a hybrid room or it's a surgical room, and you have the angiography on the same table to control any bleeding at the unpacking if needed. If this angiogram at 1 week after the unpacking is normal, we know now with the natural history of pseudoaneurysm, we know that they can appear even few months and even years after the injury. So usually we practice at 1 month, we repeat the angiography 1 month, 1 year, 3 months and 1 year to be sure to detect any pseudoaneurysm appear lately. In case where the angiogram is not normal, the discussion will be open with the anesthesiologist and the neuroradiologist, and we will discuss usually the eligibility for antiplatelet therapy, which is maybe a problem in some patients where there are some that have extended approaches with open dura, for example, when the injury occurred. So in those patients, antiplatelet may be problematic. When the discussion conclude that the antiplatelets are contraindicated in such a case. So usually we go for a sacrifice of the carotid artery, which is the simplest way to stop everything. Some teams, as you can see, have time when the hemostasis is obtained, study the collateral circulation, and they can propose even a bypass, extracranial, intracranial bypass to cover the sacrifice of the carotid. That's not practically easy in those emergent situations. If antiplatelet therapy is possible in the patient, so carotid stenting or flow diversion appears as the most good option to preserve the vessel in those cases. We can conclude by saying that there is an increasing number of neurosurgeons that may be facing ICA injuries, as there is an increasing frequency of endonasal procedures with the willingness to tackle more complex pathologies through extended approaches. Therefore, there is an absolute need for an evidence-based protocol, which is difficult because of the rarity of the published series, as I said. The endovascular treatment remains the pillar of the management of ICA injuries, even if we do not have enough data and long-term follow-up of all endoluminal reconstruction devices used, as I said, stent graft, flow diverter, and so on. That means that endoscopic skull-based surgery cannot be performed without having in the same hospital an interventional neuroradiologist, or even better, having a hybrid operating group. Finally, I emphasize on the necessity to be trained for this situation. Different models have been developed. One of these models for training on ICA injuries is one developed by an Australian team. It's a hybrid model associating a living sheep with an ENT silicone model used for endonasal surgery, which is secured on the sheep's neck with the carotid put within a plastic tube. And the trainee will have the possibility to uncover the carotid with a ronger or drill or any other instrument and provoke an injury. Another training which is important in my opinion is the simulation on crisis management. There are many hands-on these situations, and this can be done practically in the OR on a simulated patient or even on a model, high fidelity model. This will allow every member of the surgical team and anesthesiology team to know exactly what they have to do in case of carotid injury occurs, exactly as we do in aneurysm surgery. When there is a rupture, every people know exactly what they have to do. For example, broad replacement for the anesthesiologist, second suction for the resident, a packing preparation from the scrub nurse, call of the neuroradiologist. So the protocol should specify for every person what the task she has to perform in that case. So thank you for your attention.
Thank you so much, Monsef. I totally agree with your take-home messages. Practicing skill-based neurosurgery needs to handle vessel and to have a perfect collaboration with the endovascular colleagues. Thank you, it was great, very great. So last but not least, it's my pleasure now to invite my friend Luigi Cavallo to now speak on another topic, always the endoscopic transsphenoidal approach, but more oriented to the non-vascular complications. So please, Luigi, up to you.
Hello, everybody.
Hello,
Nice
Luigi.
to enjoy time with you as usual. I don't know if you see the screen.
Not yet, but it will start, I think, in a few seconds.
Okay, can you see?
Yes, I see your screen, perfect.
Okay. So I will speak about non-muscular complication. This is the trajectory we use to reach the cell. And what we noticed since the beginning was that the overall rate of complication, if compared to the microsurgical transsphenoidal approach, was lower. Even with a low number of patients we had at that time, the rate of complication was quite low. But of course, we have complication, and they are quite rare, but of course we have. And the most common are sinonasal complication with pituitary disorder or CSF leak. Then we have vascular injury or cranial nerve palsy. And of course, we can have some brain hemorrhage or stroke, which of course are even more rare. Of course, we have to distinguish the complication which can occur in standard approaches, which are mainly made for pituitary tumors or cellular lesion, and what we can have in extended approach. But even in this subset of approach, we have to distinguish those cases in which we do not have, or we have just a limited opening of the arachnoidal space, and those in which we have a wide arachnoid opening. These are the different kind of complications we can have in the different compartments. And we will start speaking about, I would say, some ENT complication that we can have. But it's even important to know not only how to treat this kind of complication, but also on how to prevent. For example, if we look for the crusting we can have after, for example, pituitary surgery, one good way to prevent the formation of crusting is to protect the nasal mucosa during the nasal step of the procedure. And we do this with the protection of the nasal mucosa using cottonoid soaked with the decongestionant solution. For example, when you have to lateralize the turbinate, we put in between the septum and the middle turbinate a lot of patty, and then we push laterally the turbinate protected by the cottonoid. And also it's useful to treat the crusting to use some nasal saline spray irrigation. This is useful especially in a standard procedure, starting from the 10-day post-op. We even don't use any more aerosol therapy. It's just enough for standard pituitary surgery to use nasal saline spray irrigation for 1 month. And you can, in case of persistence of crusting in the nose, you can use this device, which is nasal wash with saline, starting from the 20 days post-op. This is very effective, but of course, you cannot use during the first 2-3 weeks after the surgery. Another way to prevent standard is just to use irrigation washing, but in extended approach, a way to prevent synechia or adherences is to use nasal packing. And this is what we do in all the extended cases. And we leave the nasal packing for at least 3 days. And then we use nasal irrigation and washing, as I said before. Of course, sometimes, not frequently, you have to treat these adherences in the nose, but with the proper indication. Another thing you have to consider is maxillary sinusitis, which can occur when you forget to medialize the middle turbinate at the end of the procedure. So to prevent this disease, always you have to medialize the turbinate to check for the ostium or maxillary sinus. Of course, sometimes some ENT advise to reopen the ostium in case of the patient is symptomatic. And the same concept is for sphenoid sinusitis. Use extensively nasal saline irrigation, but it's also important to remember that when you approach a sellar lesion, it's necessary to do a wide splenectomy, not a small splenectomy. If you do a small splenectomy, you increase the risk to have some sinusitis in your patient. Anosmia. This can occur especially in extended approach in those cases in which you raise not perfectly the nasoseptal flap. So to avoid this, it's important to preserve the olfactory mucosa along the nasal septum. You have to recognize all the anatomical landmarks to raise properly the nasal septal flap. Of course, you have to use saline solution to wash the nose and avoid crusting. Often the anosmia can be transient, but of course there are cases in which the anosmia can be permanent. Cranial nerve injury. Also, this possibility is quite rare, especially in pituitary surgery. But we have to remember that especially in recurrent pituitary adenomas, in those with the cavernous sinus involvement, of those cases which have been already irradiated, the risk to have, for example, 6 cranial nerve palsy or incomplete third cranial nerve palsy is not so rare. So please take care, especially when you find some fibrotic tumors entering inside the cavernous sinus. It's better to avoid traction maneuver on that part of the tumor. Of course, how to treat? The only thing we can do is to do corticosteroid. and follow up this patient. In the vast majority of cases, they can this defect can be resolved. Then we move to another interesting complication, which is post-op CSF leak. As you know, this was really a big problem, especially in extended approach. In fact, if you see the rate of post-op CSF leak is very low in startup pituitary surgery. I would say today less than 1%, but it was, especially in the past, a big problem for extended approach. But with pituitary surgery, what we can do, we can close the cella or pack the cella, but not in all the cases. In fact, in the vast majority of the cases in which we don't have intra-op CSF leak, we even don't close or pack the cella. But of course, in all the cases in which you have even a small CSF leak, or even in those cases in which you have a thin supracellular cistern prolapsing inside the cellar cavity, all these cases you have to carefully reconstruct and close the cell. And in our experience, this was the most effective way to reconstruct the cell, to pack the cell and to use the extradural closure. Extradural closure is far more effective than intradural closure to close the cell. And please pay attention when you have to deal with cystic cellar lesion. They seems to be quite easy to be managed, but not in all the cases. We have a variety of cystic cellar lesion. You can have an easy case like this one, quite large but completely cystic. You look here, small opening, and you see this mucoid fluid coming out. You see a prolapsed supracellular cistern, but covered by a thick layer of residual gland. And you see here, so in case like this one, you can navigate with the angled endoscope around the cistern. And at the end of the procedure, you just have to put some thin layer of dural substitute and collagen sponge without closing the cell. But this was a case of arachnoid, of a rat-cleft cyst. Different is the situation when you have a case like this one. This was a arachnoid cyst. You see the opening of the cell. We made just a small tear on the dura. You see, apparently that was a non-communicating arachnoid cyst. Apparently, we anyway closed carefully this small hole with the fibrin glue, surgical, extradural closure with the dural dissect, but you see no evidence of CSF leak. Again, another layer of dural substitute, even a mucoperichondrium. But you know, despite all these maneuver we made, this patient had post-op CSF leak. You see here, look through the layer. That was a communicating arachnoid cyst, very dangerous. You have to be very careful with this kind of cyst. In this time, we used, of course, fat, double layer of dural substitute, again, thin layer of fibrin glue, mucoperichondrium again, and at the end, some surgical. And you see here, this time the closure was effective. So be very careful when you have some arachnoid cyst inside the cell. You can use some angled endoscope sometime to check if there is any communication with the subarachnoid space. But anyway, when you have a cystic cellar lesion, always avoid large opening, especially at the level of the dura. And in case you have a communicating cyst, you have to absolutely do an accurate reconstruction of the cellar floor. Of course, different is the situation of our extended approach. All you know that there are peculiar things when you deal with the reconstruction with the extended approach, because we have a large and irregular shape of the osteodural defect, because we have a neurovascular structure bordering the defect, And last but not least, we have always larger arachnoid opening. But we have also this factor to consider. There are patients with elevated BMI, and this happens especially in craniopharyngioma patients. There are patients already irradiated. There are cases in which we open Lilliquist membrane. There are cases in which we open the third ventricular channel. All these conditions are risk factors. But also we have to consider the intracranial pressure that we can have at the level of skull-base defect. And look, this interesting article made by the Pittsburgh group, you see how much high can be the intracranial pressure over the skull-base defect. Sometimes you can have a true herniation of the brain tissue through the skull. Here we have used a different technique to reconstruct the skull base. We used this gasket seal technique, and you see here one example. We used it for some time, but that we abandoned it completely. This technique you can use. This is a resorbable material, is a polylactic acid that we use to encase. You sometimes can encase this, but the problem is not up of that, but are around the OCR, because it's quite difficult to seal completely this defect. Then we switched to this sandwich technique, and you see this. We use fat with some dural substitute, but you see we started to put some fat inside the skull base defect. But even with this technique, you see it's quite time consuming because you have to prepare the sandwich. Then you have to encase the different dural layer around all the border, regular border of your skull base defect. So even this technique we abandoned after some time. And then we moved to the 3F technique, which is quite easy to do. This is a chondrosarcoma. You see with the wide and irregular osteodural bone opening, you see that the third cranial nerve was very close to the border of the defect. So what we do now to deal with the reconstruction, we simply fill completely the skull base defect intradurally and across the skull base defect with fat. You see a lot of fat. You see the transmitted pulsation of the brain through the skull base defect. We use just a thin layer of fibrin glue to fix the fat, and then we put the nasoseptal flap to cover. This is very fast, very easy technique. And with this technique, we had the best result concerning the rate of post-op septic. And also, if you look over the time, the fat gradually will be resolved with no problem. So these are the principles. We leave the patient in semi-sitting position, never supine. We don't use any more lumbar drainage. And also, we almost abandoned completely synthetic or heterologous material. Of course, like everywhere, the good material for reconstruction are the heterologous one. Then, how we manage pneumoencephalus without CSF leak. This happens quite frequently in a patient with a craniopharyngioma. It can be even larger than pneumoencephalus. We just hydrate the patient, and we try to prevent this pneumoencephalus using anti-Trendelenburg maneuver during the reconstruction step. And we also irrigate continuously the surgical field during the reconstruction. And we, of course, in the post-op, we rehydrate the patient. And in case of large pneumoencephalus, we leave the patient in bed rest just for 1-2 days. Of course, different is the risk of post-op CSF leak because when we have in the post-op CSF leak, we expose our patient to risk of meningitis or to hypertensive pneumoencephalus, which is different than that. So how we prevent meningitis? For standard pituitary surgery without CSF leak, we just use ultra short-term antibiotic therapy. With the CSF leak, we use cefazolin for 5 days. For extended approach, of course, we use an association of 2 antibiotics like cefazolin and vancomycin. And when we have opening of the third ventricle or extensive arachnoid opening over the skull base, we use also meropenem together with vancomycin. Of course, in our experience, we had some meningitis. And if you look the rate in the standard and as compared to extended, in extended approach is 3 times higher. You have to properly select the cases. We try to avoid to do extended approach, especially in very old people. But of course, this is a problem also for other approach, especially when the surgery is quite long, that takes more than 5-6 hours. The risk of infection in this patient is, of course, higher. Then we move at the end to pituitary problem. Of course, one of the possible situation we can have is diabetes insipidus. I will skip on how to recognize and how to treat, but it's very important to know, especially with the patient not well instructed, that minirin, desmopressin, can create a big trouble to the patient if they do not assume properly. And of course, you know, some pontine or extrapontine myelinolysis due to a rapid correction of hyponatremia. That can happen when you overuse minirin. Then hypopituitarism, of course, you have to stay in touch with your endocrinologist. And also hyponatremia, you have to recognize, because it's not so a rare evidence that we can have after pituitary surgery. And even if you discharge your patient within 2-3 days, you always have to ask to the patient to repeat sodium and potassium after 5, 7, 10 days after surgery, because usually hyponatremia start to compare around 7-8 days after surgery. Look also to some transient DI on day 1, day 2, because these are the kind of patients that can more easily develop hyponatremia. In conclusion, as Dr. Lotto said, for most surgical complications, the best strategy is the avoidance, but to avoid the complication, as he said, you have to understand the disease, the technique, and also you have to cooperate with other specialists. And especially pituitary surgery require a multidisciplinary approach to manage this special kind of disease. I think this is the end one. Thank you.
Thank you so much, Luigi, for your very, very interesting talk as usual. Maybe we have time for a few questions. Henri, I see that you already responded to some question in the chat box. Would you like to make another comment, maybe?
I have to.
Oh, if there's a question.
Henri, I said that you already responded to a few questions
Yes.
that were present in the chat box. Would you like to make another comment on your very clear and impressive presentation?
I think I have said already everything.
Everything is said.
Yes. Prevention. We have to be very careful in microvascular decompression for the small perforators. I think this is a main risk which can occur with devastating problems, and that is what the surgeon has to do. Other things sometimes you cannot really influence. For example, CSF leakage, we are so careful with plugging all the air cells, but if you have obese patients and the dura is paper thin and the mastoid is one big hole, what should you do? Marcos knows that. I think he's using fat now, not muscle, right? You are unmuted.
Yes, I think fat is better than muscle. Muscle can shrink, And for the depending on the area, so for the mastoid, I use I can still use some muscle and fibrin glue.
Yeah, because there is not much fat in many patients. So where will you harvest it? Muscle is there a lot of.
Yeah, and for the internal auditory canal, there are sometimes some small air cells there. Then bone wax is very useful to close these small cells.
But Sami said to me, this increase the rate of infection if you use bone wax in the mastoid.
This is true for the mastoid. For the big cells of the mastoid, bone wax is not useful. It can produce mastoiditis. But for the thin, very small cells on the internal auditory canal, I use bone wax, but I put it under endoscopic observation. So you see directly under the microscope, you cannot see these cells.
Yes.
Because of your tangential view.
Yeah, I always use muscle also in the internal auditory canal.
Yeah, but I can tell you, the risk of CSF leakage is about 3–5%.
Yeah.
If you use muscle.
And muscle could be the preferred choice if you have to make a tamponade over a carotid artery injury. Maybe this was one comment that was given during the talks. But most of the time when we obtain an hemostasis after tamponade, it doesn't do much to take our time to remove the surgicel, and if again be in front of a new bleeding, at that point we stop. Do someone have any comment or experience to the long-term outcome after muscle package, I will say, after carotid injury?
I have one case, what I mentioned, is sphenoorbital meningioma, and this was fine, but it was really a small hole. This was very, very small opening. Just the sharp edge of the bone went into the wall, and then I think you can have a good healing of the carotid. Yeah.
And you advise angiogram control 1 year after the procedure, or what was your management of the patient after the procedure on a long-term basis? I would say.
In the long term, we have MR angiography, so we not put him to DSA or so. I think it's MR angiography is nowadays more than enough to show a relevant aneurysm. But immediately, of course, immediately after surgery, we made a CTA. And then after 1 week, another one, and after 2 weeks, the next one, just to make sure.
Any other comment on the endoscopic approaches, complications management? Luigi, when you put fat in the pituitary or in the sphenoid sinus compartment, how many pieces of fat do you place? One big piece of fat, or several smaller one, or two pieces?
It's not easy to put just a single large piece of fat because it's not easy to insert through the nose. So we try to use 2–3 large pieces of fat. Not to use a very small piece of fat, because small piece of fat, especially when you have to reconstruct a patient with opening of the third ventricle, the fat can migrate inside the ventricle. So we try to use a large piece of fat.
Yeah.
Any other comment or question? So I think we have attended a very nice webinar. We learned a lot of things about complications. It's always difficult to speak about complications, but it has to be done, and it will improve our outcomes. We learned many things today. It was very interesting, and I would like to express my great thankfulness to all the speakers. Most of you are here every month. It's a lot of work. It's always very interesting. Thank you so much. And I will appreciate again to see you in 1 month, just 1 month. It is on March 17, and it will be dedicated to paracellular tumors. So it will be my pleasure to see you again there. And I'm sure that we we'll again have a great webinar.
And
So-
we thank you for the excellent organization.
Yeah, thanks, Miguel.
Thank you so much. But
Bye to everybody. Ciao.
it's a great teamwork, definitely, and you are very impressive in your talks, and thank you so much.
Have a
And,
nice evening. Bye bye.
Bye.
bye bye. See you
Bye.
next time.